how to select the best refractive procedure for your patient. And today we have the faculty, Dr. Rohit Shetty, Dr. Puren Basin, and Dr. Bhupesh. Please come on these chairs, please, sir. No, I think it's better. You can start from here. And I think we will take the questions after the talks, so that when one talk finishes, the question answer for that talk is also over. So you are free to ask the questions to the speaker just after his talk. And since Dr. Rohit Shetty has to leave for his next session, I'll invite Dr. Rohit Shetty to kindly talk on corneal biomechanics and its role in selection of refractive techniques. He is the one who has done the maximum work on corneal biomechanics over the period of time, and his experience and laboratory, especially in his center, is full of the equipment which can diagnose all the biomechanics of the cornea very well. So, Dr. Rohit Shetty.
Thank you, sir, and it's been an honor and pleasure to be part of your IC, and thanks for giving me this opportunity to present a little ahead of time. So the talk today is about biomechanics and the role in selection of refractive procedures. These are my financial interests, drew research grants from these companies. When you look at importance of biomechanics from a perspective of refractive surgery, in theory it helps to make an informed pre-decision, better post-op assessment of stability. Definitely it's known to reduce ectasias, and there are enough papers and articles regarding how it can be incorporated into your clinics. So now we are looking at generation where you have a balance of corneal topography and corneal strength, the biomechanical strength. There are a lot of literatures on this. Basically, what I'm going to speak, the first machine to have come out was the ocular response analyzer. Fantastic tool. It gave an insight into the mathematical domain of biomechanics. But what really lacked was it was not able to connect to the topography. So when you were not able to connect to topography, a lot of challenges happened. So that's when the Corvus was able to connect to topography, and that's why you have indices like topography, topometric biomechanical indices, and Corvus driven indices, which is pure biomechanical indices. So that changed the whole dimension of refractive surgery. The biggest knowledge gap is to plan refractive surgery other than looking at the topographies, because there are times when topographies may look completely normal, but your topography indices looks abnormal. So these are like, here it's normal, everything is normal, but here it's abnormal. But you see here, even though the topography looks normal, your biomechanical parameters, which is measured by the CBI and TBI, is completely abnormal. Here the topography has some skewing, and your bad D is showing that there's some amount of element of suspicion, but your biomechanics is stronger. So these things completely puts you into a dilemma, and these things you need to be aware as you keep increasing. And this may have an impact on your growth in refractive surgery also. So there are various patterns which we need to understand. If you look at the topography, which is from Pentacan, the bad D, the CBI and TBI, which is the from the Corvus, and all are normal. This is absolutely a no-brainer, just works very well. But then you have a biomechanical being abnormal and the topography being normal. You have a topography being abnormal and the biomechanics being normal. And you have all of them abnormal. Even this is a no-brainer. 40% of our refractive surgery falls between 2 and 3 grades, and that 40% is actually the factor which is necessary for your growth in your practice, because you don't know what to do with them. And many times you push them for an ICL, but we all know ICL's limitations is your anterior chamber depth and other things may not be good in all of them. That's when we start looking at dividing them into different procedures. And whether you do a smile, LASIK, you add an extra procedure to it, or you do a transprearche to it, and that's when the whole thing comes in. For example, here is a case where your topography is completely normal, but your biomechanics is completely healthy. So these are the procedures. You can choose any of the procedures which you have planned, whichever you're comfortable with. But there are more indices. There are more indices which looks at stress strain and SPA1. SPA1 is how the, even before the cornea indents, the response of the cornea to air puff. This is called the stiffness parameters. For me, it's one of the most important indices, which is not part of the main reading of a map, but it's there. It exists in there. So I do use a lot of them. So what I do is in my practice is to build a more organized way of it. We look at IOP is very important because entire biomechanics depends on IOP. If you have an IOP of around 25, you have to just forget about biomechanics because biomechanics behaves completely different. So that's why in your pattern, you have to understand the biomechanics is important. When your SPA1 is normal, very low, then, with this kind of cases, when you have a corneal biomechanics being suspicious, you consider a phakic lenses. So you look at the biomechanics, you look at the SPA1, and when the SPA1 is stronger, more than 100 is always stronger, then you can look at PRKs or smile extras or one of these procedures. But when it's very low and everything has an issue, then just don't do anything, just think about an ICL. So again, it gives you an insight into planning in a more organized way. So the role of topography is very important. Here, your biomechanics is normal, but your corneal topography is abnormal. This is a very interesting thing because why should the biomechanics be normal and the topography, why should the biomechanics normal and topography abnormal is because the epithelium makes your cornea to have an inferior stapling, and that can be picked up as a bad D being abnormal, but your CBI, which is the pure biomechanics, is completely healthy. So using epithelium also is very important when you try to look at how your biomechanics looks at, and based on that we can again plan our refractive surgeries and decide. So biomechanical parameters helps me to plan a bespoke treatment for my patients. When I say bespoke, it's about whether you do a PRK, whether you do a smile or a smile extra or a ICL. Otherwise, what happens is everything is based on just the topography, which is probably not right in today's context. So role of epithelium is very important because if you just use topography, the epithelium can induce all kinds of topographic abnormalities, and that's very, very important aspect, which you can probably negate it by looking at the biomechanical parameters. So we wanted to see if we can predict the outcomes, basically trying to figure out how do we reduce the corneal, what procedures would change the corneal strength. So that's how we looked at the finite element modeling. It's if in the aeronautical industry or people who makes the truck or car, all they do is they create crash simulation, not by crashing a real vehicle. They create a crash simulation by using a finite element modeling. That means you create a model and you use force to create the change. So our team used the same principle of topography and biomechanics and built a model called as AIOC, which is again creating a artificial simulus. It's called a finite element because each of these boxes are an element. It's of a finite value. And you can use different pressures, you can create different surgeries, you can create different inlays, you can do whatever you want, you can create extra procedures. And this is a software. If you have both these tools, I can share this software with you, you can use it in your practice. And what happens is if you add all this data, which doesn't take much, it runs a simulation AI driven platform and it gives you this report. And what it gives is, it gives in newtons per meter. It will tell you post-surgery how corneal ectasias, which we could get the data of pre-op from all over the world. We have more than around 30 patients across the world who had a pre-op biomechanics, and how did the machine predict it and made the machine to build an AI on it, and this is what we get. And this model gives you a very good prediction about, if I do a LASIK, I get 6 newtons of weakness. If I do a PRK, I get 3. If I do a smile, I get 6. So I can choose which one will be the least amount of stress on my corneal structure. There's a lot of areas now on LALEX or CLALEX procedures. We looked at the OPL, opaque bubble layer. We built an AI platform on this. And what we found was in 78 to 80% of them, the biomechanics was able to predict the amount of OBL created by any machine, whether ATOS, Silk, or any of these techniques. The ease of dissection was able to predict. Again, the same AI model. This is not so great, but we are reaching there. Around 60-65% of them, we were able to see how ease of dissection which can have with the particular energy setting, which is very good, because if I had to train, or the new person is getting into this, I can plan which case to give it to him based on the ease of dissection. The future is going to be optimizing the track and the line distance, the laser spots, all the energy settings today you can manipulate for all the machines, including Zima. And you can manipulate based on what type of a corneal strength you have, whatever Young's modulus you have. And these are the areas where I can choose whether I need to do an extra procedures on my patients. So in summary, biomechanics is not just a tool to look at yes or no for surgery. It's a personalized pathfinder. And when I did the in vivo confocal microscopy of ease of dissection, I found that ease of dissection has a huge implication in the quality of vision day one, and that for that the biomechanics played a role. And how does this corneal tissue respond to a particular stress? I think it's a very, very big area of interest. We call it as a BILEX, biomechanical implanted lenticle extraction. So this is a very important concept, which probably will be where the Corvus will have a huge role in the future. Thank you.
Thank you, Dr. Rohit, for this wonderful talk and making this very difficult subject somewhat easy to understand. And I think, yeah. So, Dr. Upesh, you wanted to say something.
Have most of the centers don't have the biomechanics machines, but we do have the epithelium mapping tool. So will it be of some use if you don't have the biomechanics and epithelium mapping?
So if you have a topography which is very abnormal, and if your epithelium is also very irregular, that means the topography being weaker is not a true weak.
Okay.
That gives you an indirect sense. So that means you can think about doing a LASIK. Or many times we see a baddie, a yellow or a red, we just ignore it.
Yes.
But if epithelium is very inferiorly, it's a huge epithelial thickness. That means it's not biomechanically weak, it's just that epithelium is making it look like it's weak.
Look like. Okay. Thank you, sir. Thank you, sir. Anybody else? Dr.
Any
Bajaj?
questions? Okay.
Okay, thank you.
Thank you.
Thank you, Dr. Rohit.
Thank you.
Thank you
sir.
very much.
Made it quite simple for everybody. Correct. But
So next I'll be talking on
CBI, they are
indications and limitations of various refractive procedures. So the first talk was more hugely scientific and on the basis of all the experimental data and taking the inference out of that to understand the possibility of a refractive procedure in those cases. What I'll be talking is purely clinical subject, and refractive surgery is a surgical procedure performed to provide a good vision without the need of glasses or contact lenses, as we all know. And today there are exciting times, and refractive solutions, new refractive solutions are emerging, and we have, number of procedures available to suit the patient. So what we are trying to do is not to fit one procedure for every eye. We are trying to fit the refractive procedure according to the need of the eye, and that is how the refractive should be. This is a long history which goes into this process of refractive surgery, and as you can see, 1885 started coming into the mind of ophthalmic surgeons that refractive surgery has a potential. Sato started endothelial keratotomy in 1930. Baraker thought of doing keratomiliosis, which is now known as LASIK, in 1963. And 1980, first keratomiliosis was performed. And in the meantime, Sviatoslav Fyodorov started radial keratotomy in 1974 in US and USSR, and it was considered a Russian procedure to blind the Americans. That was something initial, because the radial keratotomy procedure was not so standardized, but later it became the time-tested procedure and was performed in millions and millions of patients. Our own Indian Ranganathan Srinivasan of IBM developed a computer-controlled excimer laser, and with Srinivasan, Theo Seiler, Trockel started doing PRK in 1983. And you can imagine that in 1983, say 40 years ago, we were, kind of in the process of developing refractive surgery, and that is how the things evolved. And Ghulam Payman received first patent in 1989 for LASIK. So this is how the whole thing started. We started getting LASIK in 1998 in India, 1997 in fact. So that is how the history goes. The preconditions for refractive surgery is, as a law goes, it is over 18 and refraction should be stable for 1 year, and contraindications are active ocular disease, connective tissue disorder, autoimmune disease, use of isotretinoin and amiodarone, and latent herpes simplex, because herpes simplex is one thing which can cause real problem in healing and infection. And complications are, most common ones are overcorrection, undercorrection, and of course irregular astigmatism and infection, which are real problems at a later point in time. So we start with the techniques, and radial keratotomy was started by Fyodorov, and this was radial cuts of 90% depth, and it could correct myopia up to 8 diopters in quite a number of cases. When I started doing radial keratotomy in 1988, I would correct only up to 6 diopters with max 8 cuts. Astigmatic keratotomy was like making linear or arcuate or curvilinear incisions in the peripheral cornea for correcting up to 6 diopters of astigmatism, and today it is still being used for correcting all those cases of astigmatism after cataract surgery or penetrating keratoplasty. Hexagonal keratotomy was used, for making a hexagon of the cuts on the central cornea about 6 to 8 millimeter from the center, and this was meant to correct hyperopia, but it was not successful and created a lot of corneal haze in the center, and then was given it completely. So then surface procedures came, and surface procedures are now being back into the recognition, because higher powers can be corrected, microkeratom related complications are avoided, and dry eye is not there, and the variation in the corneal thickness was the cause of ectasia. Now, these surface procedures were not so popular when we started in 1995 when I started doing LASIK, because mitomycin C was not introduced in the science. And later on, when mitomycin C came into picture and corneal haze was not an issue for higher power corrections, these surface ablations have come back into into the picture and being done more commonly. Now PRK up to 8 diopters, and after that trans PRK or advanced surface ablation. It is not that there is epithelium is not removed. Epithelium is of course removed, but it is removed in one go from top to bottom with the excimer laser itself, and that is what is having a fancy name of trans PRK, giving a impression that there is nothing like epithelium removal in that, but it does. And then LASIK came into picture, which was initially with the removal of epithelium with alcohol, 20%, and then EpiLASIK, which was removal of the epithelium with the epikeratome. And there were the first keratome to come in the market was Moria, and I used it initially because it was a little less painful than PRK in initial cases. I personally did not do any PRK initially for first 10 years, but when this epikeratome came in, I started doing, and it was slightly less painful in the procedures. Now flap procedures, I started doing a automated lamellar keratoplasty, where one pass was to make a flap and second pass was to cut a lenticule, and then the flap was kept back. This was initially for hyperopia as well as myopia. If you made a very thick flap, the whole cornea bulged because of thickness of the top flap, which was about 350 microns. But it was not kind of a procedure which was accurate, and that is why hyperopic ALK was not very popular, but myopic ALK was good for a high myopia, like even up to 10 to 14 diopters. But very quickly, ALK came in 1989 or 90, and 1992 the excimer laser came in, where LASIK was possible. So very quickly the whole ALK system was nearly given away, only because it could make the flap was still being used, but that ALK for making the lenticule was not a very popular procedure after that. LASIK is the gold standard, which continued after that, and then it's very reliable and accurate with very quick recovery time, the wow factor, and that is how the things went from all these incisional procedures to the laser procedures. And there is a possibility of refractive correction based on true elevation called topography guided, and topography guided now has got a very nice and fancy name, the Contura Vision. And also the wavefront guided. For highly aberrated cornea, you could use the wavefront of the cornea to ablate the cornea by shot, so that the smoothing of the cornea was achieved, because of which the aberrations of the cornea will be reduced to a great extent. The only thing is that with this aberration correction, the thickness of the tissue removed was much higher, so the ablation was kind of limited to a power up to 4-5 diopters or so. But and later femtosecond laser came in. I started doing femtosecond laser in 2008, so it's now 15 years, and I started with Z-LASIK, the Zimmer femtosecond laser, making the flap, and also at that point in time intralase was also available, called iLASIK. So microkeratome related complication reduced with the femtosecond laser flaps. They were much more accurate. They were much more planar. The thickness of the flap was uniform from periphery to the center, which was like in the blade, it was central thickness of the flap was lesser and peripheral thickness was more. So that is why this thing, the femto flap became much more, also the accuracy of the flap, the standard deviation of the flap thickness was 3 to 5 microns as compared to the blade flaps which were in the standard deviation was 20 to 50 microns. So femtosecond laser, came into vogue and also became the choice, procedure of choice. So, and in the meantime, this customized aspheric transition zone by NIDAC or Contour Vision, this is the topography guided ablation which ablates the cornea with patient dedicated topography, and that is why the results are much better, and topographical correction was much superior and the quality of vision was also much better. So this is something which is now becoming more and more popular because of now the most recent thing which has come in is the lenticule procedures. The lenticule procedures are the couple of things which are important about lenticule procedures is that there is no flap created, so the corneal nerves are saved, and avoids the flap related complications, and this is done with the femtosecond laser, and this is a beautiful procedure which gives nearly very nice quality vision comparable to LASIK in 24 hours. So lenticule procedures today available are from Zeiss, the Flex or Smile, and then Clear by Zimmer, which I'm using for 15 years, and Silk is the new kid on the block with the from J&J, and also Atos by Schwind is also there. So the new thing which has come in the lenticule procedures is that there is an auto centration of the pupil, and auto capture of the pupil, and of course auto centration, and also auto capture of the cyclotorsion like in excimer laser. So the the correction of astigmatism is also to a great extent up to 5 diopter of astigmatism you can correct with a great accuracy, and most of the times the patient resume work in about 3 days. And the most recent thing which is still in experiment stage is Lyric, which is laser induced refractive index change, where the femto laser shoots in the stroma to reducing or changing the refractive index of that area. It does not do any damage or any effect on the top or behind the or bottom of the procedure, and then it it is a low energy procedure which modifies the tissue's refractive index, and it does not cause any damage to the corneal nerves, but still it's not available commercially as of now. The other procedures which are available are phakic IOL, which could be fixated in an angle or enclavated to the mid-peripheral iris or implanted into the posterior chamber. And this is another thing which is very, very accurate. In fact, it gives better quality vision as compared to laser vision correction, because there is no change in the cornea from being from prolate to oblate. So that is why the contrast sensitivity does not reduce, and the vision in dim light is also fantastic. So range of IOL, the correction is also very high. You can have minus 18 to 20 diopters of vision correction, or 10 diopters of hyperopic correction in with ICL, and you can get a IPCL made customized to your patient's need, size and power, and that is again very, very easy to procure. In about 15 days to a month's time you can get the customized phakic IOLs. Intracorneal rings were initially made for myopia, but later on their use has become limited to treatment of keratoconus, and it depends what kind of steepening you are seeing. So you have different thickness of the intracorneal rings, and at a various distances if you implant you can get a flattening of the central cornea more and more if you go in the center. And the correction of myopia was there initial, but now it is primarily for post LASIK ectasias and also keratoconus. Now another thing which has come is a allogenic intrastromal ring segment, which is a invention of Susan Jacob of Agarwal Eye Institute. She is doing CARES or corneal allogenic intrastromal ring segment, and this is associated with, along with the cross-linking, it gives excellent results for keratoconus treatment. And also these are something which is easily you can make from cornea of another patient, and it is very it absorbs over a period of time, leaving the effect which is already there. So suggested treatment options for myopia with astigmatism today, the lenticle procedures like clear or smile or silk, or otherwise LASIK like femtosecond LASIK or aspheric or topography guided LASIK, and myopia in highly aberrated cornea, wavefront guided LASIK, and hyperopia with astigmatism, femtosecond LASIK or phakic IOL. Thank you very much. So I will now invite Dr. Bhupesh Singh. He'll be talking on laser-based procedures, safety and contraindications.
After this introduction, I'll be speaking on laser-based procedures, safety and contraindication for refractive surgery. So laser-based procedures are those procedures which are done by the laser to correct the glass power or specs. It's not working. Excuse me. Not working. मिल गया? Yeah, okay. So directly coming to the selection criteria for laser procedures. So whether you are doing PRK, whether you're doing LASIK, SMILE, all these laser procedures are almost have the same selection criteria. Although some procedures give some advantage with the pachymetry, like PRK you can do in lower pachy and LASIK you are not in lower pachy. So individual has to be 18 years or older. Although in last 5 to 7 years, I am seeing that almost 50% patients are not stable at 18 years of age. So I think we should change this trend of performing LASIK surgery at 18, and we have to be very careful because patients numbers are keep on increasing up to age 20, 21, 22. So try to delay these surgeries at least for 2-3 years more and confirm that whether number is stable or not. And the thickness as prescribed is 490 micron, and it works well for all the procedures, whether PRK, LASIK or SMILE. Absence of any significant ocular pathology. The most important is normal pentacam test, and corneal tomography has to be done in all the surgeries. No surgery is advised on the basis of CCT or pachymetry. Don't go for any surgery, any small correction also on the basis of pachymetry. Always go for the pentacam or tomography test. Residual stromal bed is a controversial value. So some studies are suggesting that you should go for 250 micron residual stromal bed after surgery. Some are 275, some said 300. So there is no consensus that what should be the ideal or the accurate residual stromal bed thickness. So what we do in our practice, we try to save as much as possible. The target is always 300, but for the mild myopic patients, we can go up to 275, but not less than that. This is another important concept that we all should know, that's a percent tissue altered. So whatever you are calculating should be feed in this formula, and if it is crossing 0.4, then we should avoid doing refractive surgeries, laser refractive surgeries, and shift to the lens-based procedures. And if it is less than 0.4 with the normal topography, we should go ahead with the laser-based procedures. These are the most important tools for performing refractive surgery, whether OpScan, Pentacam, Cassini. They are different and very good tomographers available in the market. So doing the procedure on these tomographers is one aspect, but understanding how to interpret these maps is more important than having these machines. So this is a OpScan map, and many centers are still doing surgeries on the basis of OpScan. Although this is a wonderful tool, but sometimes it miscalculates the posterior elevation. But definitely it's a good screen tool, and you have to do the centers 1.5 millimeter zone, 3 millimeter zone, then 5 millimeter zone, and see the irregularities. Then so we use Pentacam in our setup, and Pentacam is the gold standard right now in the country for performing laser-based procedures. So some basic point that we have to look always. So we have to see the K readings, K1 and K2. It should be less than 47.2, because once they cross 47, chances of ectasias are there. Then look for the central thickness. What is the central thickness? And the thickness difference between the central and the thinnest point. If thinnest point is too far from the center, then there is a chances of some ectasia. And so these are the three things that we have to see in these maps. And then the next map is more important. We show the pachymetric progression, how the thickness is increasing from center to periphery, whether there is another abnormal jump or some skewing in the progression. So these values indicate those things: anterior curvature, posterior, and then this is the D value. If it is in white, then that means it's normal. If this is in red, absolute contraindicated for any laser-based procedures, whether PRK also. So this is another score that we used to follow before Entelman ectasia risk factor scoring. It is on the basis of corneal thickness, and you can calculate the score and then tell the patient that you are having this problem and you should not go for the laser-based procedures. The newer classification is the ABCD system, where you see the radius of curvature of anterior and posterior curvature of cornea, thinness pachymetry, and best corrector visual acuity. And based on these parameters, you can classify the patient between low risk to high risk. So coming to the type of laser refractive surgery, the LASIK is the most commonly performed surgery worldwide, and there are basically two types: microkeratome based LASIK or femto flap LASIK. And the next procedure is PRK or surface ablation, and the newer procedure is KLEX, keratorefractive lenticular extraction. So laser is a laser assisted keratomiliosis. It reduces the glass need, and so the common power in which we do LASIK starts from 0.5 diopter spherical to up to 10 diopter, based on the patient's corneal thickness. If someone is having 580 or 600 pachymetry, you can go for -10 also. But if someone is having 510 or 500, you can go for 3 or 4 only. So it's totally a game of residual stromal bed, how much you're saving after the procedure. Hyperopia, although the results are not very good in high hyperopia, the advice is to go for not more than 5, because above that there are chances of regression. So we have to be very careful. Astigmatism management is very good with the iris tracker. You can go up to the -6 diopter of correction with the cylinder also. So in LASIK procedure is very simple. Just you have to make the flap with the blade or without the blade with the laser, lift the flap, do the ablation, and then deposit the flap. Surgery is very simple. Learning curve is not too much, but we have to be very careful while performing these procedures, because all these patients are 6 before surgery. So you should not deteriorate their vision after the surgery. So to start with the microkeratome LASIK, so there are different type of microkeratome available in the market. So they are very high precision oscillating blade system that dock into a suction ring to create a lamellar corneal flap while the cornea is held under the high pressure. So the machine creates a vacuum, it will hold the eye, and then you can perform the flap making. So it can be of two types: translational microkeratome, which creates nasal hinge, whereas pivoting system, which creates superior hinge. So both are equally good. There is no difference that this is good or this is bad, although the translational microkeratomes are easier to operate. So this is a translational type. Just keep putting after the docking, just keep putting the saline, and just straight from, you have to go from temporal to nasal side, and it's done. Lifting the flap is very easy in microkeratome because there is no adhesion, just you have to lift with any device. Important part is once you are starting to do the laser, always dry the surface. The surface should not be wet because it will hamper the delivery of laser on the stromal bed. So dry it. Always try to save the flap with from the excimer laser. especially in hyperopic cases where the ablation zone is quite big, so you have to save with the sponge and then deposit the flap, wash the interface and deposit it. So coming to the femtosecond laser, so almost all big centers have moved to the femtosecond for almost all cases of refractive surgery nowadays. There are so many systems and almost all are very good, and in that there is no use of any blade. These femto systems are very advanced, and the best part with the femto system is that you can decide the thickness. With microkeratome, the accuracy of flap thickness is not very good. There is a variation of 10 to 20 micron in almost each case, but with the femto there is no variation. If you decide for 110, it will be 110 only in the post-op patient. So patients who are borderline cases like 510 micron, 505 micron cases, so you need an accurate flap thickness so that the residual stromal bed has to be as planned. So femto works very well in borderline cases. Surgically, it's similar to blade LASIK only. So we use Visumax for all our LASIK patients. And this is the side cut, and then you have to lift the flap. With the newer laser system, the chances of adhesions and vertical gas break and all these things are very less nowadays, and surgeries become more predictable. So coming to the excimer laser, so excimer laser is more important in LASIK surgery than making a flap. So the term excimer is derived from the contraction of the word excited dimer, in which the argon and fluorine gases are used. And the goal is to reshape the cornea so that rays of light enters the eye and focus at the correct point of retina. So the first generation examiners were broad beam lasers, but now we are using flying spot lasers, and which are faster. They have the better iris recognition, so the astigmatism correction is very good in these flying spot laser system. So these are the different laser systems available in the market, from Wavelight to Schwinn, ML90 and Nidec. So, and almost all the systems are good. Some have some advantage, some different softwares for topo-guided LASIK, some don't have. So coming to the complication, there are n number of complications that can happen with the LASIK, although numbers are very limited. And the common intraoperative complications like irregular or incomplete flaps, decentered flap, buttonholes or epithelial defect. And post-operative complication is flap dislocation in the immediate post-operative period. We have seen a lot of cases. The patient comes next day morning with a dislocated flap. Folds or striae are also sometimes there, although most of the striae you don't have to do anything. Those are micro striae, but for macro striae you have to relift the flap and do the ironing. Epithelial ingrowth is another challenging situation to manage. Once you have the epithelium ingrowth, it's very difficult to manage. It takes a lot of effort to manage these cases of epithelial ingrowth. And the most dreaded complication after LASIK is post-LASIK ectasia. The important thing is you should know how to diagnose post-LASIK ectasia. So again, pentacam come into the picture. Just see the pattern of the ectasia in the zone of ablation, and rest area is flat, and this is the elevation in the center, which means that there is a post-LASIK ectasia. And coming to the the resurgent technique, that is PRK. We started with PRK and again came back to the PRK only. With trans-PRK, with mitomycin C, PRK is now very popular. In institutes like LV Prasad, they are doing more than 50% PRK surgeries out of all refractive surgeries. Places like Narayan Netralaya is also increasing their PRK numbers from 20% to 30% of all refractive surgeries. But big cities like Delhi, Bombay is still sticking to the lenticule and LASIK surgeries. So the pros of PRK is that it gives comparable visual outcome as LASIK or SMILE. It has lower, or you can say no flap, because there is no flap in PRK. Lower risk of ectasia because you are ablating less. So you are securing the corneal biomechanics post-operatively. Quicker and cheaper recovery, although it takes 4 days time to get the good vision or settled vision, but still in long run it works very well, and there is no learning curve, you can say, in PRK. There is a long list of complications, but in my experience, the main issue is discomfort or pain in early 3-4 days. Rest all are isolated cases. And another challenging problem with PRK was haze in the past, but with mitomycin C, the haze amount is also reduced significantly. But still, once a while, you don't know which patients behave how, and some patients still develop significant haze despite using mitomycin C. So that is a main problem. If we develop some device by which we can predict that this patient is going to get haze with after any surgery, so we can avoid PRK in those patients. But still, you can take the history of keloid formation, scar formation, but normally patients don't have all those things. But still, they get significant haze. Some patients don't get any haze. So it's very difficult to judge who will get the haze, who will not get the haze. And regression is also reported more than LASIK in PRK patient. If you go for high corrections like 6-7 diopters, regressions are noted with PRK. And so this is the new technique that we are all shifting now is lenticle-based system. So this is a new terminology that have been proposed for all lenticle system, that is called KLEX. So KLEX is a keratorefractive lenticle extraction, and this is by JCRS now. So all smile, clear, whatever, it will come under the category of KLEX. So we should know the KLEX. So these are the current platforms that are in the market, and we have Visumax and Zimmer, both of them in our setup, and both are equally good. Both gives good results, although some cost factors are there in different machines, and almost all machines are coming with the auto centration and cyclotorsion correction. All these things are coming in the newer machines, and results are become more predictable or not predictable in the post-operative period. So let's see the one smile procedure. So in smile, we usually take 110 as a cap thickness, and then lenticle is cut, and this is a 2.2 millimeter incision for entering. So first of all, you have to dissect the upper plane and then go in the bottom plane. So plane identification is a challenge for beginners, but if you are a LASIK surgeon, it takes 2 to 3 cases to learn what is happening and how you have to manage. So there are different signs by which you can identify the correct plane, and then dissection. So with good optimized machine and with good surgical procedure, you don't need forceps to take out these lenticule. They comes very easily with this dissector only. So procedure is simple and but costly, and the machines are also very costly. Coming to the second part of the talk, which is when to say no for laser refractive surgery. So it's very difficult to say no to the surgery that is paying you good, but still we have to say no sometime. And the red flags are very young patients. So any patient who just completed 18 years, I try to defer the surgery for 6 months or 1 year and just see how the refraction is changing or not changing. Very high myo patients. So if you compare the result of ICL versus LASIK in these category of -8, -9, ICL patients are more happy than the laser patients. So my choice is always go for phakic lenses in 8, 9 or 10 diopters of correction. In topography, again, topography interpretation is very important. Any sign of skewing, thinning, or significant posterior elevation, we have to be very careful and very cautious before advising these procedures. Very high K reading. If everything is normal and patient is having steep cornea, 47, 48, high astigmatism but normal cornea, try to defer refractive LASIK surgeries, because they can be a form first cases and they'll become manifested after the surgery. Again, thinner corneas, 490, 495, 501, those patients are also, chances are there they will land up in ectasia in future. So we have to be very careful in those cases also. We can add up with the LASIK extra or smile extra to save these procedures from going in ectasia. Absolute contraindications, keratoconus. Any sign of keratoconus, straight no. Don't say that we can go with the LASIK or extra if there is sign of keratoconus. It's better not to do only. Go for the lens-based surgeries. Pupil size is another factor which determines the functional outcome of these procedures. The patient will get 6s, but he will keep complaining about the glare and halos. So large scotopic pupil rule out LASIK if the optical zone diameter is smaller than the pupil itself. The treatment zone should be at least as large as the scotopic pupil and never smaller than 6 millimeter. Again, the thin cornea is not an independent risk factor, but if some patient has thin cornea or borderline cornea, but the correction needed is very high. So we should avoid those procedures. And again, the 275 micron is the target residual stromal bit in all these patients. And in thin corneas, biomechanics is another factor. We should look for biomechanics also, because chances are there that thinner corneas have the poor biomechanics. And by doing LASIK or SMILE, you are adding up to that. So better not to go for these refractive surgeries in these cases. Again, pregnancy and lactation, we should not do the surgeries at all. All those patients have this malar rash, SLE, or ocular surface cases. Better to avoid refractive surgeries because their healing is different from the normal individual. Herpes cases, many times we get patient with these herpes scars. It's very tempting to do the refractive surgery, but there are many case reports which tell that it can reactivate the herpes in post-operative period. So better not to go for the refractive surgery, go for the lens-based procedures. And dry eye is another important thing. As dry is on rampant in almost everybody has having some form of dryness in their eyes. So as we are doing pentacam for refractive surgery, dry eye is equally important before performing any laser-based refractive surgeries. So go for the complete dry evaluation. Take these history of isotretinoin and amiodarone, because these patients get more dryness in post-operative period. So any patients of epithelial basement membrane dystrophy, recurrent erosions, or any other form of dystrophy on the cornea, avoid the surgery. I have seen personally 1 or 2 patients, and doctors said to me that their epithelium is not healing. It's because again, the epithelium is getting detached, and those patients were EBMD patients. So you should be able to diagnose EBMD in pre-operative period, although it's slightly difficult, but can be done. Limbal vascularization, this is also very common in contact lens users, because most of our patients are contact lens users only. They're using contact lenses for correction. So this is a relative contraindication. You can make them off the lenses for a month or so, give them glasses, lubricant, nefazoline, all those things. Once this is settled down, then we should go for the refractive surgery. But because in this situation, if you go for surgery, chances are there that blood will seep in the interface, and then it will not come out. So deep-seated eye is another contraindication for lenticle procedures, especially SMILE. Then glaucoma, small palpable fissures, keloid scar formation patients, immunosuppressed or diabetes patients. So in conclusion, proper history taking and examination can help in correct decision making. Corneal tomography is an invaluable tool before planning refractive surgeries. No laser-based refractive surgery should be done without this. And all patients are not fit for refractive surgery, so choose judiciously. Thank you.
Thank you, Dr. Bhupesh, for this exhaustive talk. And I will now invite Dr. Vardhaman Kankaria. He'll be talking on refractive surgery in keratoconus. He has got a lot of work on cross-linking and keratoconus.
Thank you, sir. Thank you, sir. And first of all, I would like to thank Dr. Bharti, sir, for inviting me and including me to his very popular course. This is an end-to-end refractive surgery course where we are actually also discussing about if it is possible to also give a refractive procedure in patients who have also keratoconus. So this is what I'm exactly going to speak to you about. This is collagen cross-linking plus procedures for keratoconic eyes in a case-based approach. I don't have any financial interest. Friends, we all know that collagen cross-linking has been successful in halting keratoconus mechanically, decreasing cornea's deformability, and halting keratoconus progression. This is proved beyond doubt. Now there are more than 2,000 published papers only on keratoconus and cross-linkings around the world. And now we already know that how successful is cross-linking for our patients. Let's look at this interesting patient that we treated back in 2007, Swati, who had come to us with progressive keratoconus with a relatively low uncorrected visual acuity of 20 by 100 and low best corrected visual acuity of 20 by 60, having a relatively thicker cornea, still having progressive keratoconus, and was contact lens intolerant. That time, Swati, of course, underwent a resident protocol collagen cross-linking, and that is where we saw this is the pre-operative topography, this is the post-operative, and this is the difference map. You will actually realize that this topographic rehabilitation is or stabilization is actually pretty good. and there is in fact a slight improvement in topography in itself. The patient, though as doctors we were extremely happy, but Swati was not happy at all, and that was because she was still having low best corrected visual acuity and she was still contact lens intolerant. So then we realized that many of these post-CXL patients do not achieve good functional vision, especially because they cannot tolerate contact lenses, many of them, and most importantly that is because of our remnant component of irregular astigmatism, which is the hallmark of keratoconus. So ideal treatment of keratic ectasia should not be only stabilization of disorder but also visual rehabilitation, and that is the whole concept of this new entity called as CXL+. CXL+ is a combination of collagen cross-linkage along with adjuvant technologies which can be called as refractive technologies in the form of topography guided PRK or PTK, in the form of ICRS, including the cares of current generation and the phakic lenses as well. The CXL Plus has been nomenclated by my mentor George Kimionis in Greece, and I'm going to showcase how this works in case-based manner. So let's look at this 26-year-old patient who had a moderate myopic astigmatism and had a best corrected visual acuity of 6/12, had keratoconus which was progressing, had a thickness of 463 microns. So we had already seen that when you're doing collagen cross-linkage, you are not actually addressing the component of irregular astigmatism. And so that we could actually address the irregular astigmatism, both George Kimionis from our group and John Konolopoulos from the other group, we published in the same issue of 2009 in JRS how you can combine a topographic guided treatment along with collagen cross-linkage so that simultaneously you can give patient not only stabilization but also improvement in their functional vision, especially if they are not contact lens tolerant. So the objective here is to regularize anterior refractive surface with topo-guided PRK to improve functional vision. It's not a refractive treatment per se, so you should restrict your ablation to less than 50 microns, and only a partial PRK should be performed. So with the same approach, which is now known as the Athens protocol, in the same patient, we improved the patient's vision from 6/12 to 6/6 vision, and this is the 2-year follow-up demonstrating an excellent regularization of topography in the same. So then we went on to do a very large long-term study, which was a comparison between the Athens protocol in one eye and the Dresden protocol, which is the CXL alone, in the other eye, which we published back in 2016 in very prestigious ophthalmology journal, where we have showcased that the Athens protocol not only stabilizes your keratoconus but also improves your functional vision, and there were a large number of eyes which actually did much better with Athens protocol than just Dresden. But what about this case? This is a 24-year-old patient who had now a corneal thickness of 420 micron. Definitely you do not have enough tissue to do a topo-guided PRK. If that is the case, the million-dollar question is, this moderate cones with thin corneas, inadequate corneal thickness for Athens protocol, so is there a way in which we can still give them topographic improvement? So we all know that mechanical removal of a corneal epithelium is an essential component of standard CXL, and there are a variety of methods which come into play of these epithelial removal technologies. You can do it with manual, with alcohol, or with excimer laser PTK. But now the question was, can the method of the epithelial removal itself help us in improving visual outcomes of our collagen cross-linking patients? So we know from this study of Reinstein, where he has done a very high frequency ultrasound, to showcase that there is a epithelial donut pattern in keratoconus. That means that the corneal epithelium is very, very thin at the apex of the cone, and annular fashion it goes on becoming thicker. So as your keratoconus is going to become progressive and it goes in more severe stages, the epithelium is going to become progressively thinner in the apex of the cone. Let's look at this with the help of a small animation. So this is a very high frequency ultrasound of one of our patients. You can see if this is depicted in this animation, and if you are actually using this differential epithelial thickness as the masking agent and use a 50 micron transepithelial PTK, which is going to top off not only the epithelium but also a bit of apex stroma, and that is going to cause a bit of flattening at the apex of the topography, thus giving rise a topographic guided simulation of our outcomes and give rise to possibly a much better functional vision to the patients. So this was the hypothesis that we started with. To prove this hypothesis, first we published a single case. This was in European Journal of Ophthalmology, and we showcased that you can see that if you look at the preoperative topography and the ablation with on the Bowman, it is very, very let's say similar. And this is the post-operative topography demonstrating that there was a significant improvement in topography of these patients post PTK and CXL combination. That is what now is called as the Cretan protocol. Then we went on to do a large-scale study again to compare the Cretan protocol in one eye and the Dresden protocol in the other. So in this cases, we had 31 eyes which were randomized between the two, and we demonstrated that the PTK with CXL demonstrated a statistically significant better outcomes when it comes to uncorrected, best corrected, as well as corneal astigmatism. So in all ways, the Cretan protocol superseded the current generation Dresden protocol. We have published now 3 papers in long run, and this is our latest paper which showcases the 4-year outcomes of Cretan. Now we will go to the third case scenario where you can actually see that this patient has a thinner cornea, extremely high astigmatism of 16 diopters or so, of course unsuitable for PRK CXL or topo-guided PRK CXL. Only PTK CXL is not going to improve his vision in any way. So in this case, then the BCVA is about 20/60 part or 20/70. What is the best modality that you have? In these patients who have very, very high regular astigmatism, it is better that you visually rehabilitate this patient with the help of any form of ICRS. You can use Intax, you can use the Kera rings or the current generation of Cares. I'm not going into the details of all of them because the restricted time, but you can do it in the manner, either you can do it in the 2-step manner where you have done a Intax first and then after 3 to 6 months do a cross-linking, or you can do it simultaneously again. And now large variety of centers are now moving to the simultaneous Intax with cross-linking in itself. So when we use this approach for this patient where the Intax SK was used, you can see the astigmatism dropped from 16 to almost only 3 or 4 diopters, and the vision improved from 20/60 to 20/70 now, 20/60 best corrected to 20/70 uncorrected. So this patient actually improved vastly and actually got a fantastic refractive outcomes. Now there are going to be a lot of patients that you pick up in mild to moderate stage who still have an excellent best corrected visual acuity by spectacles 6/12 and beyond, but these patients many times have extremely high myopia along with astigmatism, and these patients of course again cannot be helped with either PRK CXL or only PTK CXL. So in these patients, one of the best modality is to combine doing a cross-linking first to stabilize keratoconus for almost 6 months and make sure that your keratoconus is very stable, refraction is very stable, you have a reasonably good functional vision with the spectacles. Then you can choose to do a toric ICL for these patients, and these patients do extremely well. So again, looking at this patient from almost counting finger uncorrected visual acuity, the patient has improved to 6/12, and the best corrected visual acuity also improves in many of these patients because of debulking of large defocus and coma aberrations, and that improved to again 6/9 or 20/30. So this is the algorithm that we go for. Always make sure that you are actually using all the modalities that are there with you. But the CXL plus approach is a new approach. We are experiencing a major change in the ophthalmic practice today, and we are definitely providing further solutions to improve patients' quality of life, quality of vision in the form of CXL plus, which is probably the only way to go to the future with a method which offers you both a complete combination of stability and improvement in visual acuity itself, and selection of adjuvant refractive procedures have to be done in very individualistic fashion, and the patient characteristics have to be taken into account. So I would like to thank again Dr. Bharti sir for inviting me and including me into his very fantastic symposium. Thank you, sir, again. Thank you.
Thank you, Vardhaman. Thank you. Wonderful talk on
you, sir.
management of coexisting keratoconus along with refractive error. This is very comprehensive. I'm sure if you have any questions, please ask. Vardhaman is here to answer your questions.
Yeah, thank you.
So in terms of visual rehabilitation in KC patients, the last case that you showed where phakic IOL was implanted, I just want to understand how does it compare to a spectacle or a contact lens in terms of quality of vision. Quantity is definitely possible to achieve, but there's always a bit of a debate of ICL and KC is why the questions are.
Yeah, I think it's a very good question. And the most important crux of this question is selecting your patients very well. What does that mean is that your patient should have beforehand a excellent functional vision with the spectacles. So basically you're looking at patient who is already having about 20/30 or 6/9 vision, and he has keratoconus which is stabilized. Fortunately you picked it up in the early stages, and now the patient has any amount of myopia or astigmatism, but you can give him definitely same quantity of vision or better quantity of vision than even spectacles with the ICL, because in ICL many of them actually would gain about a line of vision, especially if they are already having high myopic astigmatism. When it comes to the let's say contact lenses, if you're actually talking about just soft contact lenses, then the vision of ICL will be equally or better. But if you're actually looking at the scleral lenses, of course there is in my opinion there is no comparison about the quality of vision that the scleral lenses can give. There is nothing that can match it. Unfortunately, a lot of patients do not want the hassle of using scleral lenses on day-to-day basis. And if the vision is already excellent with the spectacles, that means ICL is going to do extremely well. So let's say that ICL can be possible in about 10% of your keratoconus patients. We are not actually talking about in general about each and every keratoconus patient. So it's very important that you individualistically choose which combination you are going to do for this patient. Yeah, thank you.
How much the cone centration matter in placing this ICL cases in this eyes?
Absolutely, sir. I think another extremely pertinent question, because if the cone is eccentric, we see more irregularity in astigmatism, and these are the patients who have poorer quality of vision. So sometimes it is also possible to perform like a triple procedure in which you have done a kind of Athens protocol along with cross-linking in the first stage, where you have centralized the cone, you have regularized the cone more, you have improved the best corrected vision of this patient. Let's say that the patient has come back from 6/24 to 6/9 part vision now, and the cone is more regularized, more in the center, and that is when we can go ahead and do a ICL in the later times. Yeah.
I would say in these cases you can do a ICRS,
ICRS also,
along
yes.
with cross-linking. Let it stabilize for 6 months to a year, and then do an ICL, toric ICL to correct.
Absolutely, sir.
Yeah.
So if the astigmatism is very low, I think then a combination of Athens protocol can be good. But if the astigmatism is high and very eccentric cone, as sir has said, then ICRS of any kind of your choice, and then followed by ICL will be your choice. Yeah. So basically, TREC is an offshoot of Cretan protocol, frankly, because what is TREC is you are actually doing a PTK which is selectively at the cone. In Cretan protocol, you don't have to do it selectively at the cone. Actually, you do it 50 micron everywhere. TREC is a selective PTK which is done at the apex of the cone, which is like doing Cretan protocol at the apex of the cone.
Correct.
So in our opinion and experience, TREC performs equally exactly the same in terms of the Cretan protocol versus the TREC protocol. If you have a specific exam laser with you which is Schwend, then you can eccentrically take the PTK and do it. The good thing about Cretan protocol is you don't require a specific laser. You can do it with each and every laser right now. So basically what is done in the TREC is you are doing a PTK in the center, but you have to remove the epithelium surrounding it. So there they do it mechanically. Okay, either you can do it mechanically, or if you have a, let's say, a diaphragm, you can also do it with the PTK mode. But it is going to work exactly like a Cretan protocol. There is, in fact, the concept is exactly the same. There is no difference. Yeah.
Okay, I'll invite Dr. Purendra Bhasin now. He'll be talking on lens-based refractive procedures, ICL and clear lens extraction. He is a prolific refractive and cataract surgeon, and is well known in the international national circle for his talks and comments. Dr. Purendra Bhasin.
Thank you, Dr. Bharti, for giving me this opportunity to be in your course. And I will be focusing on ICL and clear lens extraction, because they are also a very important part. So ICL or phakic lens is a biocompatible lens between the iris and the natural lens of the eye. It is reversible, and does not involve the removal of the corneal tissue. Better option for unsuitable candidates for corneal refractive surgery. Coming to the clear lens extraction, it involves removal of the natural lens and replacing it with an IOL to correct the patient's refractive error, just like a cataract surgery we do. But this surgery is done for the purpose of refractive correction, not for the purpose of cataract removal or lens opacity removal. And it especially is beneficial for those with presbyopia or having a high refractive error, whether myopia or hyperopia, or the patients who are not suitable for the corneal refractive surgery. The advantages over the corneal refractive procedure is that it preserves the corneal integrity, its reversibility and adjustability is the forte. Wider range of refractive correction, like we can correct high myopia or very high hypermetropia, and is suitable for older patients as it addresses presbyopia and future cataract development, and we can use multifocal, trifocal or an EDOF IOL, and there is a reduced risk of dry eye as compared to the corneal refractive procedure. Coming to the phakic lenses, the indications has very well been detailed by Dr. Bhupesh. It is like any other refractive procedure case. It is for 18 years and above when the patient's refraction is stable. But phakic IOL, we generally do it for the LASIK rejects, although we can do it for the low myopes preferentially. That is the choice of the surgeon or the patient if you explain them. And LASIK rejects are the cases with high myopia, when the cornea is thin, less than a 5 micron thickness, when there is a dry eye, large pupil size, excessively flat or steep cornea. The contraindications are the presence of lens opacity, pseudo-exfoliation, zonular instability, presence of a coloboma lens, or any previous corneal or ophthalmic surgery which has been done. Any other ocular pathology like glaucoma, intraocular inflammation, corneal degeneration or dystrophy, or macular pathology or neovascularization. Like in any other refractive procedure cases, we do a complete workup. But the two important things which are useful in this procedure for the ICL or phakic lenses is that our AC depth internal from the back surface of the cornea should be more than or equal to 2.80 millimeter, excluding the corneal thickness, and the corneal horizontal wide to wide measurement has to be done, and our endothelial cell count should be more than or equal to 2000, and rest of the investigation as we do in all the refractive procedure, complete, uncorrected, best corrected, visual acuity, cycloplegic and manifest refraction, etc., etc. And angle should be not be less than 2 grade 2, and it should be wide open. So coming to the first case, this patient is a 23 years old female, and with a thickness pachymetry of 549 and 558 microns, and anterior chamber depth is 3.16 in right eye and 3.12. We planned for toric ICL in her case. This could be done by the surface procedure also, although the power was 8.5 diopters with 1.25 diopter cylinder, but surface procedure produces haze, as has been said by Dr. Bhupesh also, erratically. So PRK can be done possibly in this patient, but we prefer doing the toric ICL, and patient had on post-operative day 1 the vision of 6.9 and uncorrected vision of 6.6. You can see this. The surgery is very simple, and it takes almost or less than 5 minutes to perform. The lens comes in a BSS, and this is a front loading cartridge system, and with the help of soft tip plunger we keep the lens in a cartridge, and from the front side we pull it in the barrel of the cartridge, and then it is pushed inside the anterior chamber, which is filled half with viscoelastic, and then the lens is aligned to the axis, desired axis, and wound hydration is done, and this is the end of the surgery. It takes less than 5 minutes to perform the surgery if the patient is comfortable, and the technique is very easy, simple, and rewarding. Another case, 42 years old patient who was a high myope, and minded this is a presbyopic age group, so we performed surgery for this patient, and keeping one eye under correction, instead of 10.25 correction, we did a spherical correction of -9 diopters in this eye. So this left eye will be helping for the near vision, and the right eye for the distance vision. So this way, with the monovision correction, by under correcting it, we gave the patient a good help the patient for the good distance and near work. And this way we have done almost 16 eyes in 8 patients, patient age ranging from 41 years up to 52 years, and they were not having any cataract, and all variety of myopia was there, right from 4.5 diopters up to 10.25 and 13 diopters and 19.5 diopters, and all these patients with one eye under correction and leaving the 1.5 diopters of myopia for the patient, and one eye full correction, we managed to give good vision to them, and they all are quite satisfied. And then coming to the part of keratoconus management, this has been dealt by my previous speaker, so I will skip this part. But we have to, this is a nomogram which we follow. We optimize the cornea in a short. Day 1 post-operative, patient's vision improved to 618, with phenol improved to 612, and similarly with some refractive correction of -0.5 with 0.75 cylinder, vision improved further. So the best corrected vision, which was 24 before, was now 624. Patient was highly satisfied with his surgery. And last case which I would like to share with you, 22 years old female came to us with a plus 12 diopters of hyperopia, and she had an amblyopia in this eye also, and IOL power was 49.34 diopters and 49 diopters in the other eye. So we did a monofocal eye lens of 40 diopters, and post-op day 1 uncorrected vision was 6.9 part and 6.9, and bit later on the vision improved to 6.9 again, and for the rest of the residual refractive error of plus 2 diopters, because we instead of 49 diopters IOL power, we implanted a plus 40 diopters lens in this patient. So for the residual refractive correction, we did PRK, and she improved to 6.9, 6.12 in both her eyes, and she is very happy, but she requires near vision correction. So so clear lens extraction in presbyopic eyes, we can opt for multifocal, trifocal lenses and or EDOF lenses, but definitely the issues of PCO is there. And for the IOL power selection, we use a Barrett Universal 2 formula, which is the standard practice now in all our cases. Various studies have come, and in this particular study, which has been published in 2023, there is the refractive lens correction in 78 eyes on 39 patients. They say that the refractive lens correction is there possible, and bilateral implantation of panoptics IOL, and it gives a good correction post-operatively. Another study where they have compared refractive lens exchange with the phakic intraocular lens, they say that phakic intraocular lens is better. And the last one, which is the study which was there, they say that the refractive lens correction is equally good as compared to the phakic lens, and it is cost effective also. So to conclude, phakic IOL is the procedure of choice in all young patients and in LASIK rejects, whether it is Indian or imported. In elderly myopes, phakic IOL is the choice with undercorrection, or with a newer presbyopic correcting ICL, we can opt for that also in these with some riders in it. We can go for it because it has been recently launched in India. Clear lens extraction is a choice opted with retina clearance. That has to be very, very important, and it is mandatory. And in the presence of PVD, we can go for clear lens extraction, or if there is a early cataract present, or on eye tracy, if the lens index is high, then there are aberrations which are lenticular, which is causing the poor vision. Then also we should plan for refractive lens exchange or clear lens extraction. Coming to the hyperopes, LASIKs and when we cannot do LASIK or we cannot do phakic lens, then clear lens extraction is the choice of procedure in all age group patient. And in high hypermetropes, definitely clear lens extraction is the procedure of choice. Thank you. Thank you for your patient hearing.
Thank you, Dr. Purendra. Thank you for this wonderful talk. And we come to the end of this session. Since the next session speakers and instruction, chief instructor are now here. So we leave the dais to you, Sanjay. Thank you. We were waiting for you.